Hi, everyone, and welcome to today's Journal Club. I'd like to thank IGCS and ESCO for their support in our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We are recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentations. If you are having any difficulties or questions, please send a message in chat and our technical support will assist. We'll have time for Q&A and encourage you to submit questions via the chat function throughout today's session. And with that, I'm happy to turn it to Dr. Renny Pareja.
Thank you, Arthur, for introduction. I'm here replacing Pedro Ramirez because he is flying back from Italy to Houston right now. Everyone, please feel welcome. This month's lead article is the role of minimal invasive secondary cytoreduction in patients with recurrent ovarian cancer by Carmine Conte with us and Professor Giovanni Scambia. And I'm pleased to welcome Dr. Carmine to join us. Carmine and Professor Scambia, if he's here, or Anna, thank you for being with us today and sharing a deeper insight into his great article. I'm going to hand it over to you for a summation of the article. Please proceed.
Hi, everyone. It's great to be here. Thank you for the invitation to join this journal club and for the possibility of showing our results. The minimal invasive surgery is a very hot topic in the current gynecologic oncology scenario. When considering oncologic outcomes, that's when we must stop and remember what happened in the recent LUC trial. And next slide, please. In the recurrent ovarian cancer setting, a few investigators have assessed the feasibility and the safety of MIS cytoreductive surgery in well-selected patients, confirming the well-known benefits with respect to the open approach. But until now, only two small retrospective series, American series, directly compared MIS to open approach. And the rate of optimal cytoreduction by minimal invasive approach is consistent across the studies, ranging about from 80% to 90.98%. And survival outcomes seem comparable with the open approach. Unfortunately, there is no guidance defining the ideal candidate for minimal invasive secondary cytoreductive surgery, and no predictors of its feasibility are currently available. Therefore, the choice regarding the minimal invasive approach at secondary cytoreductive surgery is left to the surgeon's discretion. In this context, the primary aim of our study was to identify predictor factors of minimal invasive secondary cytoreductive surgery feasibility, intended as a complete gross resection without conversion to laparotomy. And the logistic regression model in the entire cohort was applied to identify these predictors factors. The secondary aim of this study was to compare perioperative and survival outcomes in a propensity-matched series of MIS and open population. Because of the non-randomized nature of the study design, and the potential allocation bias rising from the retrospective comparison between the two groups, a propensity score matched analysis was applied to balance clinical factors related to the perioperative outcomes, the survival and the postoperative complication. Next slide. This is an Italian single-center retrospective study that investigated all consecutive recurrent ovarian cancer patients who underwent secondary cytoreductive surgery at Gemelli Hospital in Rome from 2013 to 2020. Only women with the primary platinum-sensitive recurrent epithelial ovarian cancer were included in this study. Inclusion criteria to consider patients for secondary cytoreductive surgery were the absence of ascites and or diffused carcinomatosis at preoperative workup, and also the possibility of complete cytoreduction and the good performance status of the patients. The PET-CT scan was applied in all cases, and a dedicated radiologist reviewed the preoperative imaging within a multidisciplinary tumor board. And also, a diagnostic laparoscopy was used in all patients before deciding whether and how to proceed with the surgery. Overall, 276 patients underwent the secondary cytoreductive surgery, and among the overall cohort, 62 patients underwent MIS surgery, while the remaining 214 patients underwent a standard laparotomic approach. Overall, complete gross resection was achieved in 94.9% of the patients, a very high rate. And in a multivariate analysis, single disease, oligometastatic disease at recurrence, and the neoadjuvant chemotherapy approach at primary diagnosis and the lymph nodal disease resulted to be independent predictors of minimal invasive secondary cytoreductive surgery. Next slide. We compared the oncological outcomes of the two surgical approaches in a propensity matched analysis. Matching was based on the variables which resulted predictive of minimal invasive secondary cytoreductive surgery at multivariate analysis of this study. Moreover, as the main purpose of the analysis was the impact of each approach on the post-recurrent survival, additional clinical variables impacting on ovarian cancer survival and prognosis were included in the propensity score, such as the age, the FIGO stage, maintenance treatment, the BRCA status, and also the platinum-free interval. The complete gross resection rate was similar for both groups, also in this propensity matched population, and both populations were comparable in terms of number and site of recurrence. The early postoperative complications were significantly higher in the open group, about 30% in the open group versus 10% in the laparoscopic robotic group. Also considering only the severe complication, grade 2. Regarding the survival, after the median follow-up of 32 months, the median post-recurrent survival was 81 months in the minimal invasive surgery group and not reached in the open group. And the 3 years post-recurrent survival rate was 76% and 84% in the MIS and open group, respectively. Next slide, please. So in conclusion, we can say that the minimal invasive secondary cytoreduction in very selected patients is feasible and safe, although in selected centers and by select surgeons proficient in such an approach. Patients with single or oligometastatic recurrence can be offered the minimal invasive cytoreductive surgery, in particular in cases if the recurrence is localized in lymph nodes and if they received neoadjuvant chemotherapy at primary diagnosis. The minimal invasive secondary cytoreductive surgery is associated with favorable perioperative outcomes with no differences in terms of post-recurrent survival with respect to the open approach. But larger prospective studies are needed in this specific population, although we acknowledge the hurdle in performing such trials due to selection, the high selection of the patients and the complex approach. Thank you.
Thank you, Carmine, for this complete summary. We will now spend the remaining time on answering questions and group discussions. Attendees, we encourage you to submit questions via the chat function, and we will do our best to address as many as possible. We're going to start out with some questions by our fellows. Andrea, you first.
Yeah, thank you, Rini. And congratulations, Carmine, for your achievement. I would like to ask you, according to your institutional algorithm, what are the criteria by which you can decide to undergo complete cytoreduction or not? And what are the specific criteria to abort minimal invasive surgery during the intraoperative setting? Thank you, Carmine.
Thank you, Andrea. In this study, we applied our institutional algorithm for secondary cytoreductive surgeon. All patients candidates for secondary study reduction underwent a PET CT scan to detect distant metastases, such as parenchymal, retroperitoneal, or supraintestinal disease. And in addition to the radiological examination, we also used in every cases the diagnostic laparoscopy to exclude patients with diffuse carcinomatosis that is not identified at preoperative evaluation. And during the laparoscopy, in order to identify the recurrence, we explore all regions of the abdomen, such as the diaphragm, the liver surface, the bowel nodules, the pelvis. And according to our results, the localized peritoneal disease is not an exclusion criteria for MIS, especially in the pelvis. On the other hand, when the peritoneal nodes are multifocal, more than 3, for example, and involve more than one region in the upper abdomen, there are criteria to abort a minimal invasive approach. However, we don't have a specific cutoff or standardized criteria now that can guide the surgeon during the staging laparoscopy, but it's an intraoperative evaluation of the surgeon, an experienced surgeon. Thank you, Andrea.
Thank you very much, Carmine. I think that our next is Jennifer Oliveira. Are you here?
Yes, hi. Thank you so much. Really interesting
Jenny.
manuscript and work. So how do we standardize the surgeon's assessment of feasibility of optimal cytoreduction?
Yeah, thank you for the question. This is a retrospective series, so therefore has some intrinsic bias. One of them is the subjective evaluation regarding the chance to perform all surgical procedures to achieve the complete gross resection. The number and size of the recurrence is an objective evaluation. But we agree that the score as the one developed for PDS could be useful to make such evaluation and much more objective. But I would like to highlight that in our institution, all gynecologic oncology surgeons are experienced in both approach, and the team works together. So we have a standardized approach in this setting of patients. Thank you.
Okay, Carmine, thank you.
I don't know if Professor Fagotto would add some things about that.
Yes, Anna's here. Anna, welcome.
Hello.
And
Yeah,
thanks for joining us.
Hello. So actually, we try to standardize thanks to this paper, actually. So if we have like less than 3 or up to 3 nodules in the peritoneum, it's standardized. We should continue with MIS. But of course, it depends also from the experience of the surgeon and the localization of the disease. You know, there might be even small nodules which are very difficult to recognize. So sometimes, for example, we also use intraoperative ultrasound just to localize the disease, because it may be hidden within the adherences after previous surgery or after previous treatment. So I think that actually the surgery at recurrence is not standardized at all. It may differ, although you want to make your plan, surgical plan, then you can find something which is really very different. So we are trying to find like some criteria, but it's difficult to standardize, in my opinion, at least up to now.
Thank you very much, Anna. We have a question from one of our attendants, Aparna Vimal. In peritoneal recurrence, did you do field selective or total peritonectomy? And what was done in minimal invasive group?
Of course, the peritoneal recurrence is challenging in MIS approach. But in recurrent setting, our approach is a selective peritonectomy only in the area where we can see the recurrence disease. And the same in the MIS is the same of the laparotomic approach.
Perfect. Thank you, Carmine. I have a question from another of our fellows, Julio Bonaldo.
Yeah, thank you, René, and thank you, Carmine, for the interesting presentation. Well, my question is, as you mentioned in the article, the additional value of the PET CT scan with respect to CT scan is still not clear. In your experience, are PET-CT and diagnostic laparoscopy concordant in the assessment of the disease distribution? Did you have cases where a secondary cytoreductive surgery was feasible at the radiologic assessment, but not at the end a diagnostic laparoscopy? Thank you, Carmine.
Thank you, Giulio. As we know, PET-CT scan is limited by a small nodule carcinosis because the ability to discriminate hematempolically active lesions depends mainly in the spatial resolution of the PET tomograph. And for a latest generation system that, for example, the system that we have at Gemelli Hospital, the resolution is around 4 millimeters, not less. In this context, the staging laparoscopy has proved to offer a reliable evaluation of the occult peritoneal carcinosis and a good prediction of the possibility of optimal cytoreduction in the ovarian cancer patients. And such techniques should be considered complementary, the PET and the laparoscopy, because of the potential of each one to identify a different setting of the disease. The staging laparoscopy can improve the PET-CT scan sensitivity versus small nodule of carcinosis, as well the accuracy in detecting the number of nodules. On the other hand, the PET-CT scan can provide a more accurate evaluation of the retroperitoneal and or intraparenchymal disease. And so in our previous study and our experience comparing the PET-CT scan and staging laparoscopy, use of staging laparoscopy has correctly changed the PET-CT evaluation in 5 out of 65 cases studied, potentially avoiding unnecessary laparotomies in 4 patients and offering an optimal cytoreduction to another. Thank you, Giulio.
Thank you, Carmine, for your answer. Thank you very much.
Thank you.
Thank you, Carmine, as your peers call you. I have a couple of questions from the attendants. The first one is, any special techniques regarding delivering tissue during minimal invasive surgery, especially big size? And the other one is, what about recurrence in the parenchyma of any given organ?
Yes, starting with the last questions. The parenchymal recurrence is possible to remove in laparoscopy if it's a single recurrence, for example, in the spleen, or a single recurrence in the liver. But only, I think, if it's a single and not without carcinosis. Only one site. For the second questions, the special technique regarding the delivering tissue, there are no special technique, and big sites is the same as small sites, but only one nodule.
Okay, thank you, Carmine. I think we have another question from Anissa Mburu.
Yeah, if I may, Rene, I want to add that if the specimen is quite, if the specimen is quite large, of course, we can do like a port incision just to remove the node at the end. So you can simply detect and detach the nodes or the recurrence from each place, and then you can put in a bag, and then you may have like a mini laparotomy just to remove the node. This is still minimal invasive surgery. Okay.
Perfect. Thank you very much.
Thank you, Renee, and thank you, Carmine, for the great presentation. So my question is, were any patients on maintenance therapy with PARP inhibitors after the secondary cytoreduction during the follow-up period? And would you say that this would impact the survival rates by acting as a confounder in this study? And also, was there any age or BMI or any presence of comorbidities that would have had an impact on the choice of type of surgery, meaning either open or minimally invasive? Thank you.
Yes, thank you. In our study, we did not report data on maintenance therapy with the PARP inhibitors after secondary cytoreduction, because not all patients received the post-operative treatment in our institution. And considering the retrospective nature and the long time covered in the study, retrieving information for all patients was challenging. And none of randomized clinical trials on secondary cytoreduction in platinum-sensitive recurrent ovarian patients have taken into account neither the correlation between the SCS and the BRCA mutation status, nor the impact of the secondary cytoreduction in women receiving new emerging PARP inhibitors treatment. However, the extent of benefit still needs to be investigated in those patients who are exposed to secondary cytoreduction before medical treatment. And in some PARP inhibitors trials, this subgroup of patients has been included, but data are still pending to our knowledge. And this information is crucial to better understanding the recurrent ovarian cancer evolution and management in the future. Regarding the second questions, we included only the patients with a good performance status, and we not have a cutoff for age and BMI for MSI recruitment. But we analyzed the difference in the two groups between age regarding age and the BMI, and we did not report differences statistically significant for MIS respect to open approach. Thank you.
Thank you, Carmine.
Thank you.
I have a couple of questions from the audience. The first is if you were cases of VATS surgery in this study, and second, if you used to resect the laparoscopy ports when finishing the surgery.
Sorry, can you repeat the first question?
The first question is if patients underwent video-assisted thoracic surgery in this group of patients. And the second is the policy of resecting the ports of laparoscopy.
Okay, in this series we don't have the VATS in MIS in this series, and regarding the exercise, we don't have port site metastasis recorded in this series. And I'm reading the role of VATS in selection criteria. We didn't include this VATS.
Yeah, but if I may, actually, we use sometimes VATS. Sometimes we have patients who may have both, for example, disease only in the thorax, which is assessed by PET-CT scan, you know. So before going with VATS and doing a thoracic resection, we want to assess first peritoneum, because they might have a PET-CT scan which is negative in the peritoneum and positive in the chest. But then if we go with laparoscopy, we find carcinomatosis with small nodules. This happened a few days ago to one of our patients. So I think this is very useful to combine these two minimal invasive approaches in order to select in the best way these patients. And yes, if we see that there is only residual, some recurrence in the thorax, or both recurrences in the thorax and in the abdomen, which are even localized and resectable, then yes, we can do both VATS and MIS, which means robotics or laparoscopy. There was another question. Yeah, regarding the excision of the port site. No, we don't do it, but all our patients actually receive adjuvant treatment after surgery in case of recurrence. So we do believe that even though there might be like some contamination by tumor cells of the incision, then chemotherapy will do the job. And most of the cases is like this. We don't find any port size metastasis after this approach, just because this patient received chemotherapy, and sometimes they receive even sooner than patients having laparotomy.
Thank you. Thank you very much, Anna. I think we have a question from Teresa Pan.
Yeah, hello, I'm Teresa Pan. Thank you, Carmen, and thank you, Anna. It's a great discussion. I'm actually going to report a question from Ryan, one of our fellow colleagues who can't be here today. And he's asking, and also we are all asking, were the reasons that physicians chose to convert cases from minimal invasive to laparotomy reported? And was there any consideration into making this a standardized criteria to when to try MIS versus open?
Thank you for the question. As we discussed early, there is no international guidance defining the MIS visibility criteria at secondary cytoreduction. And in our institution, during the laparoscopy assessment, the criteria that guided the surgeons to continue cytoreduction by minimally invasive surgery were the identification of the recurrence and the high chance of performing all surgical procedures to achieve complete gross resection without the conversion to laparotomy. And in this series, we did not document any conversion to laparotomy in the minimal invasive group after the beginning of the secondary cytoreductive procedures, so after the laparoscopic diagnosis. And given the retrospective nature of the study, we did not report the reasons to convert to laparotomy approach after diagnostic laparoscopy. The decision was left to the surgeon's discretion and experience. As we say, there are no standardized criteria. And in our study, the group were not balanced for the rate of extensive procedures such as peritonectomy or large bowel resection that were higher in the laparotomic group. So we can say that maybe the reasons to convert in laparotomy could be the extension of peritonectomy and the bowel resection, more than one, for example. And of course, it's not easy to standardize the MIS selection criteria because there are many variables. But I would like to highlight that all candidates to secondary cytoreductive surgeon should be treated in a referral high volume cancer centers with the experienced surgeon trained in MIS. So with this characteristic, we can generalize this approach. Thank you.
Thank you very much, Carmen. I have a question for Vansa Koshashvili. Vansa, can you proceed?
Hello, everyone, and thank you all for a very interesting discussion and the article as well. Thank you. So my question is, if the proposed predictors prove to be reliable for minimally invasive surgery, would you consider using laparotomy as a primary approach for secondary cytoreductive surgery in recurrent ovarian cancer when these predictors are not present or met without diagnostic laparoscopy? So right away with open approach.
Thank you for the question. We are pretty sure that patients with more than 3 lesions identified at the preoperative imaging in different location, different area, upper and lower abdomen or mixed intra and retroperitoneal or parenchymal, for example, need an open approach to be completely resected. However, we always perform a diagnostic laparoscopy before secondary cytoreductive surgery in all cases to identify a more diffuse disease and prevent unnecessary laparotomies, delaying the second line chemotherapy. So diagnostic laparoscopy every time in this setting of patients.
Yeah, if I may, I think your question is really interesting and may be useful for people who have problems to do laparoscopy, you know, in their own hospitals. However, I think that before taking a definitive decision or giving a direct guide or direct criteria, we should try to have like a prospective study and not consider only retrospective data as granted. So I think these are like hypothesis generating, but they should be confirmed in prospective studies before considering the definitive.
Okay, thank you both. We do have another question from our audience. Is minimal invasive good enough to examine deposit in mesentery and over small bowel?
Yes, in our experience, MIS is enough to examine deposits in bowel, small bowel, and mesentery. A problem could be the adhesions, but in our experience, we can plan a good surgery about after the MIS evaluation, after the staging laparoscopy, with to achieving a complete gross resection.
I would say it's perfect. It's the best way to assess to assess deposits in the mesentery and in the small bowel. I don't think there is a better way today to assess this. I don't know about you. This is a matter of discussion, but I think it's direct vision is the best.
You cannot say any different thing.
No, but in this specific setting, I mean, I can discuss about, you know, lymph nodes or parenchymal metastasis, but not for peritoneal disease.
Okay, I do have a question, Carmine. Relapse ovarian disease is deemed a patient as a non-curable one. So after the relapse, the patient is no longer curable. Anna, you have more experience and more time doing this. Do you have experience in tertiary cytoreduction by laparoscopy or even fourth cytoreduction using laparoscopy in very, very well selected cases?
Yeah, we have few cases like this, and I may say that most of these cases are actually lymph nodal recurrences, you know, so they can recur in different places. And I think these cases can be treated by both MIS, but even by stereotactic radiotherapy. I think it's the same way to treat patients. We prefer as surgeons surgery for different reasons. One is diagnosis, histology that we can have in these patients, and we can even profile several times the disease just to see if it is changed or not. And then the second reason is that if you perform radiotherapy, then you will have a decrease in the uptake, usually of these lesions, but sometimes after a while they start growing again in the same place. So I don't know if it's also your experience. So our policy today is that if the nodule is possible to resect the nodule, then we go first for surgery, and then we reserve radiotherapy just for selected cases who cannot receive surgery anymore. And yes, if possible, we do several times in selected cases.
Perfect. Thank you very much. Arthur, did you have a question?
Yes, I actually have a question from Nuria Agusti, who cannot join today. So she says, high chances or possibility of performing surgical procedures to achieve complete gross resection was the criteria that guided the surgeons to continue cytoreduction by minimally invasive surgery. However, non-specific criteria seem to have been applied, and an instrument to predict objectively the outcomes of minimally invasive surgery is still missing in this setting. So do you think these findings could be the basis to create a future score in order to predict the likelihood of optimal cytoreduction by minimally invasive surgery? Do you think would it be feasible and worthy? Thank you.
Okay, thank you. Our results are explorative and represent a real-life experience, including a very select group of patients who underwent the evaluation with the preoperative PET-CT scan and laparoscopy for cytoreduction. And these results needs future confirmation in more extensive series and multicentric validation, and also maybe randomized clinical trial are needed. However, these findings could be the basis to design a randomized trial in order to try to standardize the inclusion criteria of MIS approach in this setting of patients. The problems could be different, in particular the stratification, the variables that we can add in a stratification system, such as the prior bevacizumab or PARP inhibitors, the time to recurrence, the single site or oligometastatic sites, the treatment at the subsequent recurrence, and also the enrollment in clinical trials. And the other problem could be also the cost of such trial.
Thank you, Carmine. We have a question from Arti Jairaj about if there was a shorter time to initiation of chemo after minimal invasive surgery cases.
Yes, in retrospective series, we know that respect to open approach, MIS has benefits such as the shorter time to chemotherapy, but we didn't analyze these variables, these factors, because not all patients underwent chemotherapy, subsequent chemotherapy in our institution, so we didn't have these results.
Perfect, Camille. Thank you very much.
I can see.
Teresa, do you have another question?
Sorry, yes. I actually was wondering if you have any data about surgeons that after performing open surgery, like asserted that they could have done it also minimally invasively, the same kind of cytoreduction?
Yeah, thank you for these interesting questions. I think there is no data about the post-cytoreductive surgeon assessment about the possibility of a MIS approach. I can say that in our institution, to help the surgeon in intraoperative decision how to proceed with the cytoreduction and to reach the goal of the best results with the best approach, at the time of the diagnostic laparoscopy, we usually share the decision with the supervisor or a senior surgeon. However, it could be interesting to develop a prospective questionnaire and perform a survey on this issue. It's interesting.
Thank you very much.
Thank you, Carmen.
Thank you.
I do have a question for Anna. In the paper, you address several times the issue that these kind of surgeries have to be performed in very specific centers with highly trained personnel. Do you have criteria for defining what is a highly specialized center, highly specialist trained people? You're mute.
Yeah. This is a difficult question for me, but I can tell you that I think that every patient with ovarian cancer should be treated in a referral center. Always, they deserve this kind of approach and treatment. So how we do here? First of all, I think it's a matter of numbers, which can make the difference. This is a matter of accreditation, and we have now accreditation by our society. So, and this accreditation is based not only on numbers, but also on surgical reports, rate of complete cytoreduction, and pathological reports, number and type of clinical trials, and so on. And regarding MIS, now there are also some certifications that are delivered by other societies regarding MIS. So I think that besides the certification, which are very basic, then you need to perform this kind of surgery. And actually today we don't know how to certify a very good or a very experienced surgeon in MIS for this kind of disease. Consider that the trials have been published only a few years ago regarding the role of secondary cytoreductive surgery in these patients. So maybe we can work on this topic to identify at least some basic criteria for surgeons who can perform cytoreductive surgery by minimal invasive approach.
Thank you, Anna. Is there any other question from audience? There is an interesting comment from audience, from Sunaina. In post-hypic cases or cases with previous peritonectomy done, additions are more. Chances of conversion is very high. What are your thoughts on that, Carmen?
In our series, it's a retrospective study. We don't have the additions rates in our series, but we can do that. We don't have a higher rate post-IPEC in my experience. I don't know if Professor Safagotti could add a comment about this.
Yeah, I may say that having received IPEC at primary or surgery or during interval debulking surgery is never an exclusion criteria in our experience. So although there might have more adhesions, we never exclude the patients from minimal invasive approach just because of this. So we always try to enter into the abdomen, explore the abdomen, and then decide. Now, I must also say that we had cases with a lot of adhesions, but none of them had received HIPEC before. So in other words, the presence or absence of adhesions is not related to HIPEC, but it seems to be related to the type of surgical procedures the patients received or the reaction that they have, which is independent from IPEC, at least in our experience.
Perfect. Anna, also unrelated with the main issue we are discussing, there is a question in the chat about the role of minimal invasive surgery in primary debulking surgery. What are your thoughts on this very controversial issue?
Primary debulking surgery means surgery for advanced ovarian cancer cases at time of primary diagnosis. And in my opinion, now we don't have any data to support the safety and efficacy of this approach in terms of complete cytoreduction and then improvement in survival. I mean, we all know that advanced ovarian cancer is such a diffuse disease that we might miss some localization, and we know that this is very important. So actually, we don't do in our institution, we just explore and decide whether proceeding to laparotomy or stop. But another group is patients with optimal response to neoadjuvant chemotherapy. Then in that patients, we have a trial, which is the LANCE trial, and we will see whether it's safe and worth for these patients.
Okay, thank you, Anna. Vansa, do you have a question? Can you do it by yourself?
Sure, thank you. So I was wondering about TRUST trial results that we are awaiting all in the close future. One of the predictors was neoadjuvant chemotherapy done for the patient. So do you think the TRUST trial results might affect this predictor?
The predictors for MIS at recurrence, you mean?
Yeah, yes, like one of the very important predictor was neoadjuvant chemotherapy. So if the TRUST trial would prove that primary debulking is the primary choice for every ovarian advanced cancer case, so would this predictor would lose its significance?
Carmine, would you like to answer? It's your stage, so if you want to answer, as you like.
We can say that patient undergoing neoadjuvant chemotherapy may receive less complex surgery at the interval debulking surgery, with consequently maybe a fewer adhesions, different pattern or recurrence, and maybe it could be a predictor of factors of MIS in a recurrent setting. In our study is one of this predictor. And maybe these results, TRUST results, could add something, but I don't think that they will affect the MIS predictor in a recurrent setting. I don't think that.
Okay.
Thank you very much.
Thank you, Carmine and Anna. This journal club has been very insightful, and we hope you enjoyed your time with us today. I want to again thank Carmine and the rest of the team for the time, and would like to thank to all of you for attending this journal club. The recording to today's session will be available on the IGCS, IJGC, and ESGO website. And please remember to join us in April for journal club on the lead article, Post-PARP Inhibitor Era in Ovarian Cancer. Thank you very much, and have a great rest of the day or night.
Thank you. Bye-bye.
Thank you to everyone. Thank you,
As
Renee.
usual. Bye. Bye.
Thank you.
Thank
Bye.
you. Bye.
Bye.